Okay, this is going to be a voiceover lecture as part of our musculoskeletal conditions, um, all the series that we'll be going over. And we're going to be talking first about muscular dystrophy. What is muscular dystrophy? Muscular dystrophy is a genetic disorder, therefore, it's passed on. Um, and it's a disorder that gradually weakens the body's muscles. So it's actually caused by incorrect or missing genetic information. And this then prevents the body from making certain proteins to build and maintain healthy muscles. So it actually changes the structure of the surface of the muscle and the internal muscle membranes, which progresses and gets worse. So there's a progressive degeneration there. And of course, when you have progressive degeneration of muscles, you're going to have weakness, you're going to have deformities and disabilities. And I'm sure you all remember that a heart is a muscle. And so if the heart is weakened, it could also lead to death. Same thing with the diaphragm, with the breathing muscle, and those sorts of things. So, this is the most common muscle diseases of childhood, and it can either start in infancy, and then certain cases of muscular dystrophy don't appear until adulthood. Um, Unfortunately, there's no cure. However, there's been some experimentation with what's called antibiotic therapy and certain advances in dealing with pulmonary complications. So again, putting people on a ventilator so that they can keep breathing for longer. Gene therapy is also being explored, um, where they're trying to map out the specific gene, um, and that looks it's from what I've read, it looks like it's a promising option, but they're only considering it for Duchenne's and Becker's muscular dystrophy, and for that I'm not even quite sure why. A child diagnosed with muscular dystrophy um, may show typical signs of development, and then at a certain time, they gradually lose the ability to walk, to sit upright, to breathe, moving the arms and hands, and then, of course, they'll have other health problems. So, how muscular dystrophy is inherited or passed on since it's genetic. Duchenne's or Becker's muscular dystrophy is passed from the mother to the son on the X chromosome. So it can skip generations. And it also can arise from a new mutation rather than an inherited defective gene. So it can just occur. I mean, there is that genetic component, but it also can just occur because of a mutation. Myotonic dystrophy, either parent can carry the defective gene. And if so, if either parent's carrying the defective gene, there's a 50% chance that the disorder will be passed on to the child. So, Duchenne's or Becker's, it's passed on from mother to son. Um, and with myotonic, it can be passed on from either parent. Other muscular dystrophy types have similar inheritance to Duchenne's or Becker's. Um, so being passed on from mother to son, again on that X chromosome. Um, it requires a defective gene from both parents. So both parents would have to have the defective gene, or it's passed on from generation to generation with males and females affected equally. Okay, so other types of muscular dystrophy is going to be affecting both girls and boys. The first symptoms when we're looking at muscular dystrophy for children, um, you may start to see them stumbling a lot. Again, everything's developing typically, and then you'll start seeing them maybe stumbling, waddling, and then eventually they may have trouble going upstairs, and then starting to toe walk, where they're actually walking on their tiptoes, is a sign also. Um, they call it toe walking. The heel actually doesn't hit the floor, so again, they're walking on their tiptoes. Um, Children may struggle to get up from a sitting position or have a hard time pushing things such as a wagon. So you'll kind of see again they're physically struggling with things. It's common for them to develop enlarged calf muscles, which is called pseudohypertrophy. Um, Pseudo meaning false, and hypertrophy meaning like a growth. Um, Pseudo, Pseudo, hypertrophy, Hypertrophy. And so you can kind of break that term up as far as medical terminology goes. But um, why this is a sign of muscular dystrophy, you would think that them starting to toe walk and walk on their toes, if you walk on your toes a lot, you're going to develop those calf muscles. And with muscular dystrophy, they don't have the proteins to build muscle. The muscle actually atrophies. And so even though they're walking on their toes, the muscle tissue is destroyed and it's actually replaced with fat. And so they're going to have enlarged calf muscles, but they're not going to feel muscular. They're going to feel more jiggly and look like there's fatty tissue there. So there's many different types of muscular dystrophy. There's Duchenne's muscular dystrophy, there's Becker muscular dystrophy, there's myotonic, limb girdle, and facioscapulohumeral muscular dystrophy. And so we're going to talk briefly about each one of these types. Duchenne's muscular dystrophy is the most common, and it is the most severe. It only affects boys, and it affects about 1 out of every 3,500 of them. It's caused by a deficiency in the protein dystrophin, and the symptoms generally appear around age 5. There can be fatigue, so they may be playing and they may have to take rest breaks more frequently. You'll start to see muscle weakening in the pelvic girdle. And so that's where you're starting to see maybe some stumbling or standing where they're bracing themselves. That proceeds to the shoulder girdle and finally affects every muscle group. Eventually, respiratory muscles are affected, and the child will end up on a ventilator, so the ventilator will do the breathing for them. They will have that enlarged calf muscles. They may have some mild MR or intellectual impairment, if you will, and they may have a Gower sign. And so here's a little video of what a Gower sign looks like. Basically, as the legs and the pelvis muscle weakens, the child uses his or her arms to crawl up their thighs into a standing position. And if they have this Gower sign, that actually helps assist with diagnosing them. And so take a look at the video. It's just a couple seconds long. It's very, very short, but it just kind of shows you what a Gower sign looks like. Here's also a picture of what Gower sign looks like. It's a series of photos that show you how somebody gets up from the floor. So you can see how they're using their arms to stabilize themselves. He walks his hands towards his feet. He braces his knees with his hands, and then he walks his hands up his thighs, so he's actually using his upper extremities to push himself up. You can also see how he's standing. You can see the enlarged calf muscles, the pseudohypertrophy, if you will, and how on the very last picture you can see how his knees are almost hyperextended. So he's using that hyperextension to stabilize his lower extremities so that he actually can weight bear and stand. Looking at Duchenne's muscular dystrophy, usually by age 9, not always, but usually by age 9, there is a loss of independent ambulation, and so they may be doing maybe looking at wheelchairs, those sorts of things. In the advanced stages of Duchenne's muscular dystrophy, you're going to have curvature of the spine or scoliosis, which we'll talk about later. And also you may see contractures of the joints. If the muscles are wasting away, the muscles cover our bone structures, right? And our joints are what help us, or our muscles are what help us move our joints. And so if we don't have the muscle or the muscle strength to do our active range of motion, we could be getting contractures in those joints that aren't being moved frequently. Most individuals, unfortunately, die by their 20s or early 30s, usually from respiratory problems, from infections like a pneumonia, or cardiovascular complications as well. Another YouTube video shows the progression. It's kind of a sad little video, but it shows the progression of Duchenne's muscular dystrophy. It's a nice video. It shows how a child's independent getting up off the floor, and then it shows how the child has eventually struggles getting up off the floor and trouble walking and those sorts of things. So a very helpful video. Take a look at it. Becker's muscular dystrophy is less common and progresses slower than Duchenne's muscular dystrophy. It's, again, less common, and it's affecting 1 in 30,000 boys, so again, less common. And with Duchenne's and Becker's muscular dystrophy, just because it's affecting boys doesn't mean that the girls may be a carrier of the gene. They wouldn't have symptoms. Becker's MD is also caused by an insufficient production of dystrophin. It usually develops during the teen years or even later than that. So Duchenne starts much earlier, Becker starts a little bit later. It follows the same muscle pattern similar to Duchenne's when you're starting to see symptoms. So it's beginning in the pelvis, and the muscles eventually that are affected move to the shoulder and then the back. Unfortunately for people with Becker's MD, many have a normal lifespan, and they can lead long, active lives without using a wheelchair. Again, that life expectancy depends on the severity of their respiratory issues and any heart complications they may have because of those muscles being affected. Myotonic muscular dystrophy has 2 types. Type 1 is congenital, meaning it's passed on and it occurs right around the time of birth. The onset can be juvenile, or it can have an adult onset. There's usually intellectual impairments. There's more severe muscle weakness that occurs with type 1. And type 2 myotonic muscular dystrophy has less severe symptoms, and it only has adult onset. And so people may complain of pain, stiffness, fatigue, that sort of thing. So overall, if you're looking at myotonic muscular dystrophy, you're looking at muscle weakness, you're looking at myotonia, or looking at that low muscle tone, the muscle atrophy or muscles wasting away. They may have frequent falls. They also may have cataracts and heart problems. They may have learning disabilities, and they may have trouble with transfers, getting up from the floor, getting up from chairs. Treatment that they're suggesting with myotonic muscular dystrophy is just genetic counseling or genetic testing and seeing if there's a prenatal diagnosis, if that's possible. They may have ankle-foot orthoses or AFOs for foot drop, wrist braces for weakness, like a wrist cock-up splint, so you can still have functional use of your hand but get that stability for the wrist. And you also would have cardiac and pulmonary monitoring. So again, no cures, but certainly things that we can do. Limb-girdle muscular dystrophy affects boys and girls equally, and the symptoms usually start between 8 and 15 years. Muscles affected first, again, are going to be the hips and the shoulders, and it eventually progresses to the arms and the legs. Progresses slowly, affecting the hips and the shoulders and the arms and the legs, but it also affects the pelvis and the back. The severity of muscle weakness certainly varies from person to person. There is a guy who has a series of videos, and he is trying to show the world how he does things. It's really quite remarkable, and that's what this video is about. I believe he's going upstairs, and so because he has hip weakness, he can't raise his leg up to take a step, because that's our hip flexors do that. And so he has to sort of swing his leg out to the side and brace it against the wall, and then use his arms to kind of pull himself and hike his other leg up. So really interesting video. And again, he has a series of videos on YouTube where he's showing people how he gets up from a bar stool, and like not at a bar, but like in his home. And so he's really trying to educate people on how he does things, so that maybe we can recommend to people how to use their muscle weakness as a strength for them by using different things to stabilize. Facioscapulohumeral or facioscapulohumeral can affect both boys and girls. Symptoms usually appear during the teen years, so again, it's a little bit later, and it progresses slowly. What's different about this one is the muscle weakness tends to start in the face, and so you'll start to see kind of more of a flat affect, or some muscle weakness, particularly in the face. It eventually moves to the shoulders and the back muscles, and in that time, the legs and the pelvic muscles lose strength as well. And so this is a touching video about a young lady who was diagnosed with, oh, you know what? This might not be the young lady. Yes, I believe this is the young lady. I went back and forth between sharing what video, and there was an older lady who was diagnosed with it, and you could see how it affected her face. And so I'm not sure if that's on the video, or if it's the young lady who liked to do bike marathons, or biking and marathons and stuff like that. And I think that's the video it is. Sometimes when you see weakness in the face, people will have difficulty closing or opening their eyes. They won't be able to puff out their cheeks. They won't be able to purse their lips together to whistle. And then as it progresses to their shoulder and back, they may have trouble with lifting objects or raising their hands over their head, which can affect all sorts of ADLs and IADLs as well. So when you're caring for a child who has muscular dystrophy, it's usually a specialist team. There's going to be a neurologist to address any neurological issues. There's going to be an orthopedist to address orthopedic problems. There's going to be a pulmonologist for breathing. You're going to see occupational and physical therapists to keep them as independent as possible as the disease progresses. They'll have nurse practitioners, you'll have cardiologists, you'll have dietitians and social workers. So you'll have just a lot of different people. What we tend to do with PT and with OT, certainly we want that range of motion and to prevent contractures. Doing resistance training and exercises to increase strength is counterproductive for somebody with a child with muscular dystrophy. So just, you're not going to cure them or take away their the fact that they're not producing dystrophin to have healthy muscles, you're not going to take that away by having them lift weights. In fact, lifting weights with people with muscular dystrophy is going to cause more fatigue. It's going to cause more harm than good. And so, us as therapists, we're not going to rehab them, but we want to keep them as independent as possible. We will probably set up home programs for and train caregivers to do range of motion to prevent contractures from happening. Um, Obviously, seeing somebody who has a degenerative disease, if we just see them a couple times a week and we do passive range of motion to their shoulders, well, that's great, but that's not going to be enough to prevent contractures if we're only seeing them maybe a half hour or an hour a week. So you're going to have to get their family or their caregivers involved to do range of motion with them, whether it be active to maintain that function, active range of motion, or passive range of motion if they've lost that active range of motion. We're also going to be looking at bracing and splinting as well, because their muscles aren't working very well. The muscles are what sort of protects the joints, right? And so if let's say I don't have a bicep in my arm, I wouldn't be able to bend my elbow. So then I would eventually get a contracture in my elbow. So it's those muscles that help us work, and so help our joints work and move. So if we have an issue with my muscle not working, we may give them braces so that the muscles don't tighten up and the joints don't tighten up for contractures. Okay, so not only are we going to be doing range of motion to prevent contractures, but we may also give some splinting or some braces as well. Excuse me. Eventually, we may do some power wheelchairs. Seating and positioning is really important. We don't do a lot with ventilators, but we may have to, or it's important for us to remember that they may be on ventilators at night. And when we're doing seating and positioning, or if we're doing positioning with them in bed, some of the tubes that we would have to work with their ventilator. Certainly as OTs, we would look at adapting the environment and teaching them to use assistive devices to, again, keep them as independent as possible as they're slowly losing function. So it may be positioning items for easy reach or at wheelchair level, having some sort of lightweight adaptive silverware, using different assistive technologies like switches. The possibilities are endless, but what I want to reiterate is you are not going to do strengthening activities with these people because we already know the progression of the disease. We're not going to stop that. Let's see here. Muscular Dystrophy Association. I included the link there. Very, very good website with more information about muscular dystrophy. And that's all I have for muscular dystrophy. Thank you.